This video and I'll try to forward it throughout. It's an 8-minute video. I was given 10 minutes, but I'll try to finish it in 4. Yeah.
We appreciate it.
4, 8, 10 minutes.
Keynote address is
10 minutes, so
just
don't
keep it,
keep it
yeah,
on.
keep
10,
it
10. But I'll try to finish it in 4 or 5 minutes by forwarding it if I can forward. Yes. Okay, so the whole idea of trabeculectomy is to create a guarded filter so that aqueous filters out uh, into the into the bleb that you create. But in all occasions, it may not filter further from the bleb due to a ring of steel formation, which we are seeing out here. So this is one of the major causes for high IOP after a few months of trabeculectomy. You see a good bleb, but then it's not filtering beyond the bleb. So the initial step is to get a good exposure and then do a very meticulous conjunctival dissection without any injury to any other area of the conjunctiva to prevent a buttonhole. I also prefer to remove the tenons capsule separately so that there's no encystment later on. While doing the bleb, you can do it in any shape, a triangular or a square shaped, it doesn't really matter. But what matters is that it is a clean dissection, uniplanar. Try to do it on cadaveric eyes first before moving on to actual patient so that your dissection is very clean. You can use either the 15 number blade, 11 number blade, whichever you're more comfortable with, or a scleral knife itself. An important point to note is that do not go up to the limbus in the periphery on either side. Stop short of the limbus. In the center, go further ahead so that you expose the limbus very well. If you go further ahead out there, you would end up with a leak in that area. So that is one point that you should know. Let's forward it a bit. Another dissection video. So again, demonstrating how you do it with a crescent knife. If you're more comfortable with a crescent knife, you can do that, and then cut it on either side with the 11 number or 15 number blade. Again, taking care not to go all the way till the limbus. Now, whatever you do, the healing process will try to scar and therefore lead to failure. Therefore, we use antimetabolites, mitomycin. While using mitomycin, there are complications that everyone dreads, a bleb leak or a very thin bleb. So do not use a single big pledget which is soaked in mitomycin. Try to use multiple pledgets so that you are spreading it over a more diffuse area. You get a good posterior drainage. Posterior drainage is the key for long-term bleb survival. Just keep a note of the count of number of the pledgets that you are inserting and remove all of them after 1 or 2 minutes, whichever you are comfortable with. That in the meanwhile, so after that, what you have to do is remove a part of the limbus, the ostium you are creating there. Again, you can do it either with a punch as demonstrated there, or with a freehand dissection. But again, remember not to go up to the sides of the wound. Keep a good margin on either side, again to prevent side leakage from the bleb, which will lead to a over-filtering bleb due to a leakage out there. So when you do that, it's going to filter more posteriorly, which is ideal. While doing a peripheral iridectomy, the idea is to remove any obstruction that can be there. So just enough so that when you visualize through the ostium, you are not seeing any iris tissue out there. So pull out very gently only a bit of the iris, and then verify by pulling the flap that you are seeing the red glow through it. As long as that is there and there's no iris tissue visible, that is enough of a dissection. You may not actually see the iridectomy unless you pull it with a dialer. Suturing, I generally use one epic suture and then releasable sutures on either side. I don't have access to a laser to release these sutures, therefore I prefer releasable sutures. The technique is not very complicated once you get a hang of it, and it would take not more than 1 or 2 cases to get a hang of it. You pull that loop there, just pull the knot, do not lock it further, just cut that off, repeat it on the same side. I go from outside the conjunctiva into the flap area so that it does not rub on the cornea later on. The same thing is being demonstrated, and I'll show you how easy it is to release it also. Just pull it in the center to create a small loop and then knot it. So 2 or 3 throws, just pull that. That's the end of it. Now when you pull that one, it releases so easily. My time is not yet up. There, it's released. Okay. Similarly, you then go on to the conjunctiva. Take a anchoring suture at either side so that it does not slide back. Use a firm area of the conjunctiva which you have not dissected. Do that on either side. I would also prefer to use a single mattress suture in the center so that leakage is prevented from that area. The whole idea of suturing is to, in this particular area with the mattress suture is to prevent a bleb leak. The one slide I showed you that had leaky bleb, so that is what would drive people from not doing a trabeculectomy when needed. Trabeculectomy numbers are indeed lesser, but it is indeed a very gratifying surgery if you follow these key steps so that you don't land in complications. Thank you.